So today we're going to spend a little bit of time on dermatological disorders in children. This is something that you'll see very common no matter where you work. If you see pediatrics, urgent cares, ERs, primary care, any of those, you'll see this frequently. So just a brief overview of the pathophysiology. The skin is composed of 3 layers. The epidermis is that thin outer layer that functions as a protective barrier. It's composed of 5 layers of stratified squamous epithelium, and new layers are shed and replaced every 28 days. The dermis is that thick middle layer, contributes to the strength, support, and elasticity of the skin, regulates heat loss, provides defense of the skin, and is composed of fibrous connective tissue. And then the subcutaneous layer, which is composed primarily of adipose tissue. It contains arteries and arterioles. It works to insulate, cushion against trauma, provides energy, and metabolizes hormones. So when you see a kid with a dermatologic condition, sometimes it can be overwhelming because there's so many different things that can be, and they can all kind of look the same in some ways. So there's some important questions to ask before you get started. When did it start? How long have they had this? And what's their most common concern? Is it itching? Is it just how it looks, that it looks bad? Are they worried about it being contagious? They may worry about them going to school. Are they having fevers? What's their most common concern? That might help point you in the right direction. Where did the rash start? Where did it initialize? Sometimes these parents, they'll have a little rash in one spot and they don't come in to see you until it's spread throughout their entire body. So knowing where that started is important. How long has it been present? Does it itch? What have you used to try to treat it? And I always ask this question because a lot of times it really gives me a lot of clues. I tried this, it didn't work, or I tried, 1% hydrocortisone and it seemed to work, but didn't get rid of it all the way. That kind of makes me think, well, maybe that just wasn't strong enough. They didn't use it long enough, and that helps. Any associated symptoms, fever, malaise, vomiting, diarrhea. Has anyone else been sick at home? Recent exposures, what's going on in school and at home, any allergies, any medications they're taking, and then that family history. And family history is helpful too if it's things like atopic dermatitis that can be congenital. So for your physical exam, you're going to look at the location and type of lesion. Where is it? What does it look like? The color, any color changes, size and shape. For color changes, like what did it start looking at? What does it look now? Is it erythematous on the outside and it's hypopigmented on the inside? Or is there any yellow crust? Or what color does it look like? The shape, the size, the arrangement. Is it linear? Are they clusters? How are they arranged there? The distribution of the lesion. The border, is it a well demarcated border or not? And then consistency. What does it feel like? Is it rough? Is it smooth? That kind of thing. So there's a lot of different types of lesions and they're described differently. So I want to run through those quickly with you. And this is just kind of a list that you really just have to memorize. You'll see this on boards and you'll need to use this terminology when you chart. So the comedo is a plugged, dilated pore. This is typically a white or black head. A cyst is a palpable lesion with definite borders filled with liquid or semi-solid material. Macule is a freckle, so it's a flat, non-palpable, discolored lesion 1 centimeter or smaller. A nodule is a raised, firm, movable lesion with distinct borders and deep, palpable portion that is 2 centimeters or smaller. A nevi is a circumscribed chronic lesion. They can vary in size, usually brown, black, or pink, and this would be a mole. Verruca is a raised, round, or oval growth. A papule is a solid, raised lesion of varied color with distinct borders larger than 1 centimeter. This would be a skin tag or razor burn. You would see that. Pustule is a raised lesion filled with pus. Often this can be a hair follicle or sweat pore. Vesicle is a blister filled with clear fluid. And a bulla is a vesicle larger than 1 centimeter. So this would be a blister, whereas a vesicle you would see in varicella. And then a wheal is a fleeting, irregular shaped, elevated, itchy lesion It's pale in the center, slightly red at the border, and this would be a hive. You can also get secondary skin changers from lesions. Atrophy is the thinning of the skin, crust, dried exudate or scabs. Desquamation is peeling sheets of skin. Erosion is an oozing or moist, depressed area with loss of epidermis. Excoriation is an abrasion or removal of epidermis from scratching. Fissure is a linear wedge-shaped crack that extends into the dermis. Keloid is basically a scar, and you can see a picture of one in the top right. Lichenification is a thickening of the skin with deep visible furrows, so right there on the right. And you would think, of course, of psoriasis with that. Scales is thin, flaking layers of the epidermis, and then striae is fine pink or silver lines where the skin has been stretched. And for those women that have had babies, you know what those look like. There's also vascular lesions of the skin. So angioma or hemangioma is a papule made of blood. You can see one there. Ecchymosis, the bruising. Hematoma is a collection of blood from a ruptured blood vessel that's larger than 1 centimeter. Petechiae or pinpoint, pink to purple macular lesions that don't blanch, and they can be 1 to 3 millimeters. Purpura is purple macular lesions larger than 1 centimeter. And then telangiectasia is a collection of macular or raised dilated capillaries. So there's lots of different diagnostic testing you can do with dermatology. Here's a list here. Most of these are diagnosed just by the way they look and their presentation from their history and physical. But you can do microscopic examination of the skin scrapings using potassium hydroxide or KOH. That's used to examine for fungal disorders, and you'll see the hyphae and spores, and I'll show that to you in a little bit. There's the right Giemsa stains, and they examine for bacteria, white cells, and viral lesions. You can do a culture, you can do skin testing for allergies, skin biopsies, and then you can always get that CBC and sed rate to look for inflammatory processes or elevation of your white blood cells. So we're going to talk about medications in a minute, but there's different preparations of topical medications, and it's important to know what these are and how they're made so that when you order them, you know what to order. Most of the different medications come in a cream, a gel, a lotion, an ointment, and you can decide which one you want. So the creams are more oil than water. They're less occlusive, but they're better in high humidity and in summertime and when you're putting it in body folds, but it must be applied every 2 to 3 hours. It evaporates more frequently and has to be reapplied more frequently. Gels are alcohol-based. They have good skin penetration, but they may burn on application. These are used for acne and in hairy areas. Lotions are mixtures of powders and waters. They're useful for drying, cooling, or soothing, and emulsion lotions contain more oil. Ointments are best used for dry skin, so you're trying to hydrate the skin. Mostly oil, very little water. It's the most potent concentration of medication. So it leaves a greasy feel, but you don't need to apply it more than twice a day. Pastes are a combination of powder and oil. They're difficult to apply and remove, but they provide dryness and protection to the area. Powders absorb moisture, reduce friction, decrease itching, and increase evaporation. And then there's also shampoos that we'll talk about. And I like the little graphic in the upper right-hand corner. It talks about how much oil versus water are in these different combinations there. So gel, you can see, is a lot more water and less oil. Creams are kind of in the middle, and then ointments is high oil and less water. So there's lots of different types of medications, and we're going to talk about these when we talk about the different diseases, but they're antibacterial, antifungal, antiviral, anti-acne, anti-inflammatory, antipyretic, topical calcineurin inhibitors. These are immunosuppressive and anti-inflammatory. It's used for atopic dermatitis when other therapies don't work. There's scabicides and then hair and scalp preparation. So there's different types of corticosteroids, and I'm not going to cover this again, so I wanted to touch base with it. I may just say prescribe a corticosteroid, and you need to decide what potency you're going to use, and they range from low to high potencies. The table 37.1 is a great table that lists all the different different corticosteroids and their potency and how to prescribe them. It varies from low, which is your hydrocortisone 0.5%, and to high. And one example of that is butamethasone 0.05%. The hydrocortisone, of course, 1% or lower is available over the counter, and everything higher than that would be by prescription. Triamcinolone, I just wanted to mention because that's a very popular one that you may see a lot, and that's kind of right in the middle, a medium potency corticosteroid. So the first one I want to talk about is impetigo, and this is very common. It's a very contagious bacterial infection of the superficial layers of the skin. It's caused by A. streptococcus, Staphylococcus aureus, or MRSA. You can see the pictures there. It can be non-bullous, which is 70%, and that's the one on the left, or bullous, which is more blistering, and you can see that there on the right. It's honey crusted on an erythematous base. That honey crusted, remember those words, you will see them again, and you can see that picture there has kind of that honey crusted oozing. They can have pruritus, fever, weakness, and diarrhea that accompanies the bullous impetigo. It occurs more often in the summer. The differentials you want to think about are herpes, varicella, nummular eczema, contact dermatitis, and scabies. For management, if it's a very minor case, if it's very localized, not too close to the mouth, you can go with a topical antibiotic, and you would use Miprocin topical 2% 3 times a day for 5 to 7 days, or Retapumulin 1% ointment BID for 5 days. The Miprocin is the one that I see the most. And again, this is just for a very localized infection. And then if it's more severe, if it's real close to the mouth, something like that, you're going to want to think about oral antibiotics. And that's if they have multiple lesions, or the non-bullous. Cephalexin, Augmentin, clindamycin, there are your choices. And again, I will never test on doses because you will look those up in practice. I know that you're not going to look at this slide and memorize those doses, but just keep in mind what you may want to order. If there's no response in 7 days, they're going to swab beneath the crust for a gram stain culture and sensitivity. And just some education for the parents. Talk about cleanliness, hand washing, and how to prevent the spread of disease. They can't return to school until it's been treated for 24 hours. And pigment changes can last weeks or months. So just prepare your parents for that, and then they won't come back in for another appointment when they're worried about those pigment changes. Next, we're going to talk about cellulitis. Cellulitis is a localized bacterial infection, often involving the dermis and subcutaneous layers. It commonly follows an insect bite or animal bite, trauma, or some kind of penetrating wound. The common pathogens are Streptococcus pneumoniae, S. aureus, and they're the most common. H. flu causes buccal cellulitis or infection over the joints. MRSA can be seen, but typically when you see that, it has a pus accumulation with it. And if it's around the perianal area, then it's Staphylococcus aureus. Your history and physical, so they'll have a previous break in the skin. They may have fever, pain, malaise. They could be irritable, have anorexia, vomiting, and may have a recent sore throat. If it's around the perianal area, then they could have stool retention, constipation, or blood streak stools. For your physical exam, it's going to be erythematous, indurated, tender, swollen, warm areas with poorly demarcated borders. It can have a blue to purple tinge, and that's usually if it's H. flu. You may see some regional lymphadenopathy. It has a well-demarcated perianal erythema up to 2 centimeters around the anus. And then there's something called erysipelas, and that is a superficial variant of cellulitis. It's rapidly progressing. It's tender, bright red with sharp margins, and has that orange peel look and feel. And you can see a picture of that. If you feel it, actually feels like an orange peel. It's more red than an orange peel, but has the look of it. For your diagnosis, you just treat by the look of it. The CBC in cultures, if the child is febrile, appears ill or toxic, or is less than 1 year of age. And then do a gram stain in culture if it's an unusual looking organism or if pus is present, or if the child just looks real toxic and ill. For management, you want to hospitalize them if it's a febrile neonate or infant, if they look acutely ill or toxic, or if it's periorbital cellulitis. Antibiotics, you want to begin immediately. If they're hospitalized, then you're going to go to Pen V. If you suspect Staphylococcus, you're going to do an initial dose of IM Rocephin, and then you can give one of those medications there on that list. And then if it's suspected H. flu, you can do Augmentin or third-generation cephalosporins. Complications associated with that are recurrent perianal streptococcal infections. That's just really recurrent. You'll see it over and over again. Septicemia, necrotizing fasciitis, or toxic shock syndrome. So these can progress quickly. They can get ill real quickly. So that's why I emphasize really starting those antibiotics as soon as possible. Next one is folliculitis or furuncle. This is a superficial bacterial inflammation of the hair follicle. A furuncle is a deeper infection with involvement of the base of the follicle. The most common pathogens are your Staphylococcus aureus, P. aeruginoso, and E. coli. It is more common in males than females. History, a lot of times you'll see hot tub use, and of course this is in older people. You'll see that, and they'll have folliculitis all along the bottom of their legs. They may have pruritus. They can have tenderness if it's a furuncle. And if it's real severe, they can have occasional fever, malaise, or lymphadenopathy. For your physical exam, they'll have discrete erythematous 1 to 2 millimeter papules or pustules on an inflamed base that's centered around hair follicles. They may have involvement of the face, scalp, extremities, and it will be tender. And then pruritic papules, pustules, or deep red to purple nodules. Management, they can apply a warm compress after washing with soap and water. You may use topical keratolytics like benzoyl peroxide 5 to 10% twice a day for 5 days. You can also use topical antibiotics, erythromycin or clindamycin twice a day for 10 to 14 days for the superficial folliculitis. If it's really severe or widespread, then you're going to use cephalexin or dicloxacillin for 7 to 10 days. They want to avoid shaving until it's resolved and follow up in 1 week for folliculitis, or if it's a furuncle, have them come back the next day. You may actually need to do incision and drainage if it's a bad one. Now we're going to talk about candidiasis. These are fungal infections of the skin or mucous membranes. It's caused by Candida albicans. It's more common in infants, obese children, adolescents, and chronically ill or immunocompromised children. It also can be seen as a secondary infection with antibiotic, steroid, or oral contraceptive use. History and physical. For your history, you're going to ask about that recent use of antibiotics or steroids, and then it usually occurs in warm, moist areas. So there's different areas that you may see it in. In the mouth, you could see thrush, which that was on the previous slide there, and that is friable, adherent white plaques on erythematous base. You could see colitis, and that's cracked lips, or angular colitis, and that's fissured and inflamed corners of the mouth. So this picture here on the right has colitis in the whole lips and angular colitis as well. You may see it in the neck, groin, or axilla, and that's bright erythema in the folds. Could see it in the diaper area, and that's moist, beefy red macules and papules with sharply marked borders and satellite lesions. Vulvovaginal area, that's when they have the thick, cheesy yellow discharge with erythema, edema, and itching. And then you may see it on the nail plates, and you'll see transverse ridging of the nail plate, loss of the cuticle, and chronic paronychia. For management, it depends on where you see it. So if it's thrush, you want to order oral nystatin suspension. They're going to use that 4 times a day. And if they're older, they can swish and spit that out. If not, just put it on some Q-tips, or if you're in the hospital, those little green sponges that they use to do oral care, those are great to use for nystatin. If they're breastfeeding, you want to put the oral suspension on the mother's nipples right before feeding to eliminate reinfection with that. It sometimes requires a second course to completely eliminate the infection, and if it's resistant, you may need to give oral fluconazole for 14 days. For cheilitis, the book actually recommended clotrimazole trope, which is a dissolvable pill. They can dissolve in their mouth 5 times a day for 14 days. If it's that angular colitis, I've even seen them just put some clotrimazole on the corners of their mouth, being careful not to get it in their mouth, for a week or so, and that should clear it up. For skin infections, you can use a topical antifungal, and there's a list there: nystatin, miconazole, clotrimazole, ketoconazole. You can apply it to the skin. If it's diaper area, you can apply it to the diaper every time the diaper is changed until the rash is gone, plus an additional 1 to 2 days. So that's an important note and education piece to do with your parents of the child. If inflammation is severe, you may want to do 1% hydrocortisone that can be applied for 1 to 2 days. Keep it clean and dry. Again, if it's in the diaper area, frequent diaper changes, use a mild soap and water, rinse it well, and avoid any other powders to the area. If it's nail involvement, you can use topical antifungal cream twice a day, and this will take months, and these are hard infections to get rid of. Oral fluconazole can be used if it's a severe or resistant infection. So we're going to continue on with fungal infections of the skin and talk about the tinnias. So first is tinea capitis, and this is ringworm of the scalp. And it can show in different ways. This picture here is a very classic picture, but it's actually a pretty significant infection, a pretty significant ringworm, and very easy to diagnose. Not all of your tinnias will be this easy to diagnose. But it can show as diffuse scaling without obvious hair breaks. You can have discrete areas of hair loss with stubs of broken hair, or you can have patchy hair loss and scaly lesions with raised borders. You'll have scaly pustular lesions, and it occurs in a non-inflammatory stage for 2 to 8 weeks and then becomes inflammatory and real bad if it's not treated. For your history, you want to ask about hair loss, any itching, and then any contact with any other infected person or a pet. A lot of this can be transmitted from a pet. So your physical exam, you'll see scaling, erythema, or crusting. They'll have bald patches or broken hair. They can have black dot tinea, and that's the picture there on the right there. That's tiny black dots in the area of the hair loss, and that is from T. tonsurans is the infecting agent with that. And then if they have fine gray scale on the scalp, that's from M. canis. And think about that. That's canis, canine, dog. So that's the infection from pets. So it can present in different ways, but really if you see patches of hair loss, that's not from something like pulling out hair or systemic body infection where you're seeing systemic illness, then it is probably a tinea capitis. For diagnosis, you can do a Woods light, and you can see yellow-green coloration, and that's only with the M. canis kind of infection. If you do a KOH examination of a scraped hair, you'll see similar to what's here in this picture. The typical view you should see with a fungal infection, and that's your hyphae and spores. The hyphae are kind of the long stringy things, and then the spores are the dots. Some people call this a spaghetti and meatball kind of picture. You can see the meatballs and the long stringy spaghetti. So anytime you look at something that you see this picture, then it's some kind of fungal infection. You can also do a fungal culture of a completely plucked hair. So you need to completely pluck it out and do that culture. Management, the gold standard is griseofulvin, and that's a 6 to 8 week treatment. They can also use topical treatments, which is shampoo with selenium sulfide 2.5%, econazole or ketoconazole 2%, 2 to 3 times a week for 4 weeks. So they're going to shampoo it on, lather it up real good, let it sit there for about 5 minutes, and then rinse it off. Steroids may be necessary if it's a really severe inflammation, if it's really a lot of swelling there. Check other members of the family and pets to make sure that they're not treated, and if it's pets, that they're not infecting other people. Continue that medication until 2 weeks after the culture is negative, and that's what we talked about. You need to get down deep to the roots. So if you stop as soon as the visual evidence of the disease is gone, then it will probably come back and they'll have a recurring infection. Follow up every 2 weeks until new hair growth is evident. Hair regrowth, complete hair regrowth, is slow. It could take 3 to 12 months. So you don't need to see the patients every 2 weeks for a year. But once you start to kind of see little hair growth coming back, then you know you've treated it and that hair will regrow. Make sure you educate parents that they want to launder their sheets and clothes in hot water and vacuum frequently to prevent other people in the family from becoming infected or reinfection of that person. Next is tinea corporis, or infection of the body, and this is a superficial fungal skin infection found on non-hairy skin of the body, and there's a good classic picture of it. You can see that hypopigmented area in the middle and that circular erythematous area. So for history, ask if they've been around someone infected or an animal who's been infected. For your physical exam, it's an annular or oval with one or more flat, scaling, mildly erythematous circular patches with a red scaly border, and I've talked about that clearing centrally. Lesions spread peripherally, so they may say when you ask where was the initial infection, they'll kind of point to the center of their trunk, and it's just spreading out, so it'll spread that way. For diagnosis, you can do that KOH scraping, do a fungal culture, or most of the time this is just diagnosed by appearance. For management, for a superficial or localized infection, you can do topical antifungals. So your miconazole, clotrimazole. You want to avoid the combination of antifungal or steroid combinations. So some physicians will actually combine those medications together, but that's not advised. If it's a very severe inflammation, you may need to use some steroid cream, but just educate them to use the antifungal, and then several hours later they can use that steroid cream. Apply the cream twice a day until clinical resolution, and that can take up to 1 to 4 weeks. If it's an infection on the face, or if it's a very extensive infection, then you're going to use that griseofulvin, treat for 2 to 4 weeks. The medication should be taken with fatty foods because that actually increases the absorption. So this is going to be the one time that you educate your patients to take a high-fat food along with their medication. If it's an extended therapy for more than 8 weeks, which can happen, so you're going to treat them, say, okay, let's do this treatment for 4 weeks, come back and see me then. If they still have it, then they're going to do a second round of treatment until they can get rid of this full infection. But if they're using that griseofulvin for more than 8 weeks, then you need to monitor their CBC, LFTs, and renal function. They used to recommend monitoring before you even start the medication, but now they just recommend it if it's a continued treatment. They can return to school 24 hours after the initiation of treatment, and follow-up should be in 2 weeks or sooner if symptoms are worsening or spreading. Next, your tinea curis or jock itch. This is a superficial infection of the groin, upper thighs, or just the folds of that groin area. For the history, a lot of times they're in a hot, humid weather. They may wear a lot of tight clothing, not wearing cotton clothing, so cotton fabrics that don't breathe very well. Physical activity that can have chafing and sweating in that area. And of course, we think of contact sports, especially those that use a cup, so wrestling, football kind of things. For your physical exam, they're going to have erythematous to slightly brown with sharp marginated plaques with a raised border or scaling, and central clearing may be present. So I didn't put a picture, but this is very similar to what you see. The tinea is on the body, it's just in the groin area. It's usually bilateral and symmetric, but that if it's just unilateral doesn't mean that it's not tinea curis. It occasionally occurs in the perianal region on the abdomen or buttocks, so it can spread into those areas. Management is the same as your tinea corporis, so you can start with topical treatments if it's minor, or use the griseofulvin if it's a more major infection. Treatment is usually needed for a full 4 to 6 weeks. Don't use steroids in this area because of atrophy and striae that can develop. Educate them to wear cotton underwear and loose clothing. Allow that area to breathe and get dry. So after a bath, to dry it real fully and let some air in there before they get dressed. And then if they're in a contact sport, to make sure they bathe as soon as possible after the event. So if they're wrestling, as soon as their match is over, to go in and bathe and get that area clean and dry. Now you're onto the tinea pedis, and this is a fungal infection of the feet. You'll see vesicles and erosions on the instep of one or both feet. They can have fissures between the toes with surrounding scale and erythema. They rarely can have diffuse scaling on the weight-bearing surface of the feet. It's more spread like this, and you can see these are pretty classic pictures. For history, they tend to have sweaty feet. They're not wearing breathable socks or wearing nylon shoes. They'll have itching, burning. They can be really stinky feet. They'll have cracks, abrasions, nicks, and cuts, and a lot of times contact with damp areas, so swimming, going into locker rooms, those kind of things. For your physical exam, they'll have red, scaly, cracked rash. They may initially present as white peeling lesion that becomes erythematous, vesicular, macerated. They look just real nasty and can have fissures. Management there, topical antifungals applied 1 centimeter beyond the border until 7 days after clearing. And I didn't mention this for the tinea corporis on the body or the cuirass. You want to put that topical medication beyond the border of the rash to make sure that you're getting all of the rash and making sure it's not spreading. So teach them that, to go 1 centimeter beyond the rash. Usual treatment takes 3 to 6 weeks. Griseofulvin is really only needed in rare cases, so I would start with that topical treatment and then progress if needed. Rinse your feet with plain water, or they can use a water vinegar solution. Make sure they're drying the area very carefully. Keep those feet dry using cotton socks and avoid itching. So I'll teach them to keep cotton socks with them. If they're playing sports like soccer or basketball, to keep dry socks and maybe change at halftime if possible, so that they can keep their feet as dry as possible. If they're wearing tennis shoes, to wash those in the washing machine with soap and bleach solution, and then follow up in 2 to 3 weeks to make sure that it's improving. The last one is a tinea vesicolor. This one looks a little bit different. You can see that in the picture. It's not that erythematous infection that we've seen. It's a superficial fungal infection, also called pityriasis versicolor. And we're going to look at another pityriasis infection here in a few minutes. But they have kind of that same presentation on the core, but they look a little different, and we'll look at that. This occurs more commonly in adolescents. It's common in warmer weather and hotter climates. Breastfeeding infants can get it from their mothers, and they'll have facial lesions. For the history, you're going to see they should have an occasional mild itching. In their physical exam, they'll have multiple annular scaling, discrete macules or patches ranging from salmon color to brown. So there can be a wide range in coloring. It's typically seen on the neck, shoulders, upper back, chest, midline, and face, so kind of the trunk area. And they tend to have a raindrop pattern, and you can see some of those in those pictures show that raindrop pattern. The lesions don't tan in the summer, and they become darker in the winter months. So that might be when they may have had this infection for a while, and they go out in the summer and it doesn't tan and it looks worse because the other skin is tanned. Or in the winter, these areas are becoming darker, so they may come in at that point. For treatment, you're going to do your selenium sulfide 2.5% lotion or 1% shampoo applied in a thin layer several hand widths beyond the lesion for 30 minutes twice a week for 2 to 4 weeks. So they're going to take this shampoo or lotion and really lather it on, let it sit there for about 30 minutes, and then rinse it off. They can lather it on, then wear a bathrobe around or something and let it sit there for 30 minutes before they jump in the shower. They're going to do it twice a week for 2 to 4 weeks, followed by monthly treatments for 3 months, and that prevents the reoccurrence. Older adolescents can use 2% ketoconazole shampoo. In resistant cases, it may require oral antifungal treatment. You can use fluconazole there. If they're taking that fluconazole, you actually want to encourage exercise where they sweat, because they sweat that medication out and it enhances the concentration on the skin. I thought that was pretty interesting way to treat it. So now we're going to move on to viral infections of the skin. The first one we're going to talk about is herpes, and as you know, herpes can come in a wide variety of types and symptoms. It's transmitted by close personal contact with an incubation period of 2 to 12 days. There's HSV1, 2, and herpes zoster we're going to talk about. So HSV1 can show as gingivostomatitis. Those are group vesicles on erythematous base that ulcerate and form white plaques. They can have lymphadenopathy or halitosis. There's also herpes labialis. This is a cluster of small, clear, tense vesicles with an erythematous base that become weepy and ulcerated, progressing to crustiness. This is a classic cold sore, and it's typically unilateral. And then there's a herpetic whitlow. You can see that picture there on the right. This is a deep appearing vesicle on the hands, fingers, lips, nose, cheek, forehead, eyes, or genital area. Then there's HSV2. These are group vesicopustules and ulcerations with edema. Primary lesion is usually in the vaginal mucosa, labia, and perineum in females, and on a penile shaft or perineum in the males. Now I say that HSV1 is typically oral and HSV2 is typically genital, but not always. There is ways to transmit back and forth, and so you may see the different types appearing in different ways. I actually saw in clinicals a woman who came in with a primary herpes genital lesions, and she had been married for 15 years and immediately thought that her husband, that there had been some infidelity. Well, it turns out it was a HSV1 infection that he had had long term, and she got it that way. And so he had blood work done to determine that it was HSV1, just to kind of clear himself. And so it's just an interesting case where you would see that happen. And there says HSV2 oral lesions are possible, and then regional lymphadenopathy, typically with that primary presentation. So as you know, with these HSV2, their primary presentation, they can be very ill. It can be very painful, a lot of lymphadenopathy, almost like a flu-like symptoms from that initial presentation. And then from then on, they're just having those lesions of the herpes when they have a recurring infection. Herpes zoster, that's a recurrent varicella zoster caused by reactivation of latent varicella zoster infection. We know of this as shingles. It's very rare in childhood, but I wanted to mention it just because it's a part of these herpes. So for management, you want to first use boro solution, and this is a combination of aluminum sulfate, tetradecahydrate, and calcium acetate monohydrate. So it's that combination, and it's soothing on different things that are irritating. So people will use it on poison ivy, poison oak, or sumac, or other painful rashes. And if you do it as a compress 3 times a day, it can alleviate some of that discomfort. And that can be bought over the counter. Oral acyclovir is most effective when started in 3 days of symptom onset, and it can shorten the course and alleviate symptoms. Can be used in children over 2 years of age, and typically is only used in the following cases there. So if there's any other underlying skin disorder, if it's a very severe outbreak, if it's an immunocompromised patient, if there's systemic symptoms with a primary genital infection, so we talked about how painful and miserable that can be, or if they have a lot of inflammation in the mouth. Topical acyclovir is typically the treatment, can be done 5 times a day for 5 to 10 days. Consider antibiotics if you are suspecting a secondary bacterial infection. You can see there what you would use. Oral anesthetics are used for discomfort, and there's something called magic mouthwash if you haven't heard of this before. It's used a lot in pediatrics for any kind of oral lesion. We'll talk about it again when we talk about hand, foot, and mouth disease, but it can use to kind of numb and alleviate the pain with oral lesions that will help children eat and drink so they don't get dehydrated. There's different variants of magic mouthwash you will see. This one here is a very common one, or some use different combinations, just what the physician is comfortable with. So this combination is viscous lidocaine 2%, and that is done with a prescription. Liquid diphenhydramine, and then the aluminum or magnesium hydroxide. So any Maalox or Milcomag, something like that, that has that. And it's a 1-to-1-to-1 ratio. You just mix the 3. And if the child's older, they can swish and spit. Or if they're younger, they can put it on a Q-tip and kind of rub it on the lesions, and it can help a lot. Some physicians use this without the viscous lidocaine, so it's just the diphenhydramine and the mag hydroxide. And that also works as well, just doesn't have as much of a numbing effect. You want to refer if it's a newborn, immunocompromised infant, a child with atopic dermatitis, because these can be pretty complicated, so they want to go to a derm to see them, or if there's a lesion in the eye or on the eyelid margin. So next we're going to talk about molluscum. If you have not seen this, this is very, very common. It's a viral skin infection with little health risk. It's benign, but it's pretty contagious. So because of that, it's very common. And you can see the picture there. The one there on the upper right is very common of what you will see. It often disappears without treatment in a few weeks or months, but it can take up to 4 years for those to go away. It spreads by direct contact. Incubation period is 2 to 7 weeks, but some have reported as long as 6 months. It can be itching, but it's not always itching. For your physical, they're very small, firm, pink to flesh colored, discrete papules 1 to 6 millimeters. So that's what you see in the upper right. The lesions can progress to being umbilicated, and that is a very common term you'll hear, is something you may see on boards. If you ever see it's an umbilicated lesion, think molluscum, and they can have a kind of cheesy core. Surrounding dermatitis is common, so the top right doesn't have really any redness with it, but they can become red and irritated, especially if they're itching because the child's scratching them. It can present as a single papules or in clusters that you see there. Genitally grouped lesions can be present with sexually active or abused children. So think about that if you see this in a young child. It can be severe in children with eczema or immunocompromised children, and that's because the skin is already broken and susceptible to those infections there. For management, there's really no consensus or evidence-based literature to support any treatment that's successful really over a placebo treatment. Different physicians have different viewpoints, and they've been educated in different ways about this. So some of the things you may see are mechanical removal, and this should be done by a dermatologist. Some say that irritants such as duct tape applied at night can help because it can remove layers of those skin and help get rid of it. And then there's several different topical medications that are sometimes used and have been studied. Some physicians use this, some pediatricians don't. I don't like to use them because they can create scarring. So, they'll have these lesions for a few months, but then they go away and there's no scarring. But if you treat it, it can lead to scarring. The ones you'll want to progress to possibly treat, and typically I send them to a dermatologist just because they can do this better, make it look better, and have less incidence of scarring. If it's in a really cosmetically worrisome area, so on the face or near an eye, near the mouth, something like that, then I would definitely refer them for treatment. But most parents, I just educate and let them know this will just go away. Don't worry about it. It won't cause any problems. If it does itch or cause problems, they can give some Benadryl or some kind of antihistamine to prevent that itching. But typically I just leave them alone. Next, we're going to move to warts, and this is a proliferation of the epidermis and mucosa affected by some variant of HPV, and there's over 100 variants of HPV. And of course, when we think about HPV, we think about the genital warts that cause cervical cancer, but these also cause the different kinds of warts. Transmission is from fomites or skin-to-skin contact. Incubation can be from 1 to 6 months and possibly up to years, which is crazy. For a physical exam, they'll look different depending on where they are. Common warts, which is the verruca vulgaris, are elevated, flesh-colored, single papulars with scaly, irregular surfaces and occasional black pinpoints. They're asymptomatic, so they're non-pruritic, and they could have multiple there, like you see on that hand. And these can be found anywhere in the body. Then there's plantar warts. These are found on weight-bearing surfaces of the feet. They grow inward and disrupt skin margins, and there's a good picture of one there, and they can be very painful. And then there's flat warts, and these can be on the face, neck, and extremities. These are small, slightly elevated papules. Management, there's, again, no single effective treatment. Recurrence rate is high. There's keratolytics, which these are the over-counter things that you see. These can be effective. They just can take a long time, and parents need to be on top of management with them. These come in different forms. There are some that are liquid. I recently found one that's almost like in a chapstick tube, and I found that to be very effective because You can be more consistent about where it's placed. With the liquid dropper, it's hard and you have to let it dry. But with that chapstick tube, you just wipe it right on, and then the next time pull off the layer skin and keep working on it, and it'll get it off. There's also shown to be some evidence that usefulness with the duct tape. So you do the occlusion method. Put the duct tape on for 12 hours a day for 6 days. Soak the area. After 6 days, soak the area and scrape away that epidermis. And continue this until you've gotten down deep enough to get it out of the way. And then cryotherapy is what you can do in the office. And this is using the cryotherapy. Apply it 2 to 10 seconds until an area 1 to 3 millimeters beyond the wart turns white. The problem is it is painful, and retreatment is often necessary. There's also podophyllum, surgical excision, and laser treatments which can be used to treat it. Next, we're going to talk about lice, and now's the time to start itching your head because we're going to talk about lice and scabies. This can affect the head, body, or pubic area. An adult female deposits 6 to 10 eggs per day in a glue-like substance that's in a waterproof shell. Those nits incubate for about a week, and then they grow into adulthood in another 1 to 2 weeks. So head lice live about 100 days, and each one lays about 100 nits. So you can see if this has progressed for a while, their head can really be infested with a lot of lice. For your physical exam for head lice, the lice can be visualized. You can see there in that picture the small white oval cases that are attached to the hair shaft, and these are usually attached about 4 millimeters off the scalp. They're usually found behind the ear, the nape of the neck, and the back of the head. Body lice can happen. These aren't as common. It's excoriated macules or papules that may be present, and a hemorrhagic pinpoint macule is seen where the louse actually extracted the blood. And then the pubic lice, that's excoriation, and small bluish macules and papules may be present in that area. Management, lice are growing resistant to available pharmacological treatments. So you may have heard about these scary resistant lice out there. So treatment failure is common. But you want to recommend to parents to get the pediculocide, and that's permethrin or pyrethrin plus pyperonyl butoxide, easy for me to say, but those are what's available over the counter. They'll put that on, apply that solution, and really just instruct them to follow the instructions. They put that on, allow it to soak into the head for however long the box recommends, and then they'll wash that out, and then they have to remove the nits, and this is a long and tedious process. They need to separate the hair into about 1 centimeter sections and use a very fine tooth comb and remove all those nits. And they're sticky and they're hard to get off. So they need to use that comb. They need to stretch them out, get them out of the hair completely. Then you also need to clean the environment. So check family members and friends and treat anyone who's infected. Clean sheets, towels, and clothing with warm water, washing it all. Store unwashable items in a plastic container for at least 2 days. Vacuum frequently, and then soak your brushes and combs. And they can return to school after treatment. There may be some nits left, but typically that medication has killed them, so they should be dead and not growing, so they can return to school at that time. So next on to scabies. This is caused by the parasitic mite Sarcoptes scabii. They burrow into the epidermis, causing intense itching. It's highly contagious and spread through close contact or shared clothing. So if you think about lice, usually lives on hats or combs. Scabies will live on clothing. The female might burrow into the skin, laying up to 3 eggs as it burrows in. The eggs hatch in 3 to 4 days, mature in 10 to 14 days, and they have a lifespan of 15 to 30 days. So physical exam, you'll see a characteristic lesion with an S-shaped burrow. These typically come on the webs of the fingers or on the insides of the hands, folds of the arms and armpits, the belt line, buttocks, or genitalia. So they want warm, dark places. So that's why the belt line is very common, the armpits, or in those folds of the hands. That has a vesicular pustular lesion, can be found in infants and young children. And secondary lesions include itchy papules, red-brown nodules, crusting, and excoriations. So for the diagnosis, you can do a microscopic exam of scraping from an unhatched burrow. in saline or mineral oil. Don't use KOH because that'll kill it and you won't see what you want to see. But you'll see that unhatched burrow and those eggs and that scraping. There's also something called the burrow ink test. You apply a drop of ink or rub a washable felt tip pen across the suspected burrow, wipe it off and examine under a microscope, and that just helps you to see it better. For management, you want to use permethrin 5% cream. This can be used on children as young as 2 months safely. So instruct the parents to apply a thin layer of cream on the entire body from the neck down. And then you're going to rinse 8 to 14 hours later. So I usually recommend putting it on before bed, putting some old big t-shirt or bathrobe or something over them once it dries, and sleeping that way and then rinsing it off in the morning. And then they probably will need to reapply in 1 week. Depending on what's happened with the disease after that one treatment. Antihistamines or topical 1% hydrocortisone can be used for itching, which can last several weeks after treatment. So just educate them about that. Simultaneous treatment of close contact. So if one kid has it, they'll probably want to treat all the other kids to prevent it. Wash all linens and clothing in hot water and for a hot dryer for at least 20 minutes. Vacuum frequently. Store non-washable items in a plastic container for a minimum of 1 week, and they can return to school 24 hours after treatment. Next, we're going to move on to acne vulgaris. This affects 80 to 85% of individuals between 11 and 30 years old in the U.S. There's 4 mechanisms that contribute to acne, so a little bit of pathophysiology with this. They have sebaceous follicles that become plugged with keratinous material. Then colonies of P. acnes grow deep in the follicle, and then the other infectious agent can be M. furfur. Overproduction of sebum and androgen production increases that expands the follicle, and then that becomes inflamed and the pustules form. So this is kind of a long process, so you need to make sure you educate your parents, or at this point the adolescent, that treatment won't fix this in a day or two. Treatment is going to take weeks to kind of get to the source, because that acne that you have on your skin now, that pimple that you see, developed 6 to 8 weeks ago. So I'm going to start treatment now, and it's going to prevent them from forming in 6 to 8 weeks, but that takes time. So your history and physical, you want to think about family history because it does tend to be passed down. Stages of pubertal development and menstrual history, so where are they on the Tanner scale? Think about facial and hair products used. Are they using things with a lot of oils? And think especially about hair products. Are they using some kind of moisturizing hair product that can get on the skin and help clog those pores? What medications are they taking? Have they used currently using or previously used any acne treatment? Sports participation, things like football helmets can really help the acne develop and grow. What job are they doing? And this mostly you would think about working at McDonald's or something where they're working over greasy, hot grease that can get up in those pores. And if they have any other medical conditions, and what I think about, of course, is PCOS, that polycystic ovaries, that can show higher androgen levels and they can develop this severe acne. So your physical exam lesions are mostly found on the face, back, and chest. There's different types of lesions. The non-inflammatory lesions, microcomedone, and this is just a follicular plug, so kind of the typical acne that you would think about. The open comedone, which is the blackhead, the closed comedone, which is the whitehead, and then you'll have your inflammatory lesions, and these occur secondary to rupture of the non-inflamed lesions and include papules, pustules, excoriation, lesions, crusting, nodules, cysts, and scars. And you can see that picture. There's a pretty good picture of them. You can see the blackhead and whitehead and papule on the left, and then the pustule nodule that gets the real severe acne on the right. And it's important to know what these look like and how many they are, because that's how you're going to classify how severe this acne is. And we're going to talk about this in a minute. So when you look at the face, kind of count. Okay, I see about 20 whiteheads, some papules, there's a pustule, there's a bunch of nodules. Know about how many you see when you examine the patient. So here's their classifications. I'm sorry the picture is a little blurry because they blurred out the eyes, but I thought it was a good picture there. Mild acne has less than 20 comedones, less than 15 inflammatory lesions, and less than 30 total lesions. Moderate acne has 20 to 100 comedones, 15 to 50 inflammatory lesions, and 30 125 total lesions. And then severe acne is your cystic acne. You can see that grade 4 down there in the right corner. So more than 5 cysts, a total comedones more than 100, total inflammatory lesions more than 50, more than 125 total lesions. And that just looks so painful to me. But there are lots of treatments we can do. So it's important to know your classification so you know where to start with your medication. So first, basic treatment. This is treatment that doesn't involve medications, but what the patient can do. First, they want to understand that the acne often worsens before improving. We kind of talked about that. It takes time, 6 to 8 weeks to prevent more lesions from starting. And when you start these different treatments, it can sometimes inflame the lesions they have before they finally go away. They want to wash their face twice a day with mild soap. So some things that are recommended are like the Dove soap or Aveeno, Cetaphil. They all make some really good mild soaps. They want to avoid scrubbing, picking, or squeezing. Apply hot soaks to pustules. That'll help draw that out and relieve that pustule. All products that they use should be labeled non-comedogenic, and typically those are the ones that are advertised for acne treatment. Discontinue use of aggravating substances such as any oil-based products. We've talked about the hair products or other oils. Makeup, it's important to think about on their skins. Identify aggravating factors such as stress, hot, humid weather, jobs involving frying oil. And then results can take months, and that adherence to treatment is essential. So they need to understand it's going to take a while, because if not, they'll try for a couple weeks, think this is making it worse, I'm going to stop this, and not get to the point where they relieve the problem. So here's the list of different medications you can use. I'm going to go through what they are, and then we're going to talk about where to start. So the first is your benzoyl peroxide cream. This is an antibacterial against P. acnes, and it's available in 2.5% all the way up to 10%. And the 2.5 are your over-the-counter medications that they can get. Then there's tretinoin. Those are your keratolytic. They decrease the cohesion between epidural cells, increases the epidermal cell turnover, and it's anti-inflammatory also in the treatment. They can expect redness and dryness with initial use and expect 6 weeks of therapy before noting improvement. And this is photosensitizing, so educating about sunscreen or really just the avoidance of sun exposure. Then you could progress to your topical antibiotics. This is clindamycin, erythromycin, or dapsone. This is often used in combination with benzoyl peroxide and tretinoin. And I know I like to use a lot of times benzaclin. It's a gel that they can put on their face. It's covered by Medicare, Medicaid. So I'll instruct the patient to wash their face and then apply this to their skin, and they see a lot of improvement with this. Oral antibiotics that can be used are doxycycline. That's the main one used, but you can see the other ones that are used. But it's a low-dose doxycycline. It's usually added when topical treatment has been insufficient. It can take up to 3 months to see full effects. So if you see them come in, I tried doxy before and it just didn't work. Well, how long did you try it for? You need to be on this for a long time before you see the effects of it. They do need to taper off slowly if they're using it. So if they're using 100 once a day, go to 50 once a day, then go to 50 every other day, then 50 every 3 days, 50 once a week, and really taper off slowly, or they can have a return of really severe acne with that. Long-term or repeat therapy is often needed, sometimes for years, until they get through puberty. Combined estrogen, progesterone, hormonal contraceptives, so the pill, can be really useful in females, adolescent females that have pretty severe acne, because it can help regulate those androgen levels and decreases sebum production. The full effects are not noted for 3 months, so educate that they need to continue on this. And the last thing there is your Accutane. This is treatment for severe cystic acne that does not respond to other treatments. The usual course of treatment is 4 to 6 months, and it can reduce that nodule count by 70%. Females must use 2 forms of birth control, and this is really generally only prescribed by a dermatologist because it needs such high follow-up, and it's just important for those two forms of birth control. There's actually an I Pledge program that's done by the practitioners and by pharmacists. And you have the patient sign this, that they will remain on two forms of birth control because the teratogenic effects are so severe. And I saw several patients in the PICU that had severe congenital abnormalities because their mothers were on Accutane. So it's a real thing. And it's also photosensitizing as well. And then carefully monitor for that mood destabilization or suicidal thoughts that can occur with this medication. They start, if they present with mild acne, typically you're going to start with a topical retinoid and then consider adding a topical antibiotic or benzoyl peroxide. So I typically will start with that retinoid and then say come back in 6 to 8 weeks. If it's not better, we'll add in more, and you kind of titrate your way and move your way down in treatment. For moderate, you're going to start your oral antibiotics with that topical treatment as well. And then if it's severe, you're going to use oral antibiotics with a topical retinoid and then Accutane if this is ineffective. Next, we're going to talk about atopic dermatitis. This is an acute or chronic inflammation resulting from hypersensitive reaction to a substance, and this can be irritant or allergen. And there's a lot of different things that can irritate. Dry skin dermatitis, and that's your typical eczema we're going to talk about in a minute. Nickel dermatitis, this is a very common sensitivity. Lip liquor dermatitis. Photodermatitis, and this is sun exposure following contact with plants or juices. So a lot of times lime or lemon, and then sun exposure, and they can get that dermatitis. Plant oleoresin, so that's your poison ivy, oak, or sumac. Juvenile plantar dermatosis, this is dryness, cracking, or erythema of the weight-bearing surfaces of the feet. And then latex dermatitis. Presentation, the area of involvement often clues to the causative agent. It's their ears, think about nickel, or around their wrist. Are they wearing a new watch? Where is the exposure and where's the problem? If it's on their arms and they've been outside, think about your poison ivy. They are generally very pruritic. A chafed appearance with shiny, mild to severely erythematous peeling or dried fissure skin. They can have red patches with plaques with secondary scales, erythema, vesicles, and weeping in the acute stage, and then hyperpigmentation and lichens are seen in the chronic stages. And that lichens occurs because they're itching, and you get an overgrowth of those skin cells and get that developed. Management, the Burrow solution that we talked about, or oatmeal baths with cool compresses applied for 20 minutes every 4 to 6 hours. So for the oatmeal baths, they can put some oatmeal in an old sock, soak it in the tub, and kind of squeeze it out and get that oatmeal in the bath. Or Aveeno or other products make products that can help with that oatmeal bath. And we've talked about that Burrow solution already. They can do water and petroleum or lanolin-based products that can help restore the moisture to dry chafing areas. Topical corticosteroids 2 to 3 times a day, and then oral corticosteroids if the area is more than 10% of the skin, or it's a severe infection or near eyes, mouth, something like that. Oral antihistamines for itching, and then resolution can take a full 2 to 3 weeks. So now we're going to talk about eczema. Eczema affects 2 to 20% of children that are younger than 14 years at some point in their life. 30% of them also have hay fever and asthma. We'll talk about that in a second, but 70% of families also have allergic symptoms in their family. So other members of the family will have those allergic symptoms. So it begins what we call the atopic march. They'll have eczema in infancy, and then as they go older, they'll present with food allergies, allergic rhinitis, and asthma. And I've talked about that triad before that goes together very commonly. And this occurs between the ages of 2.5 and 6 years. Pruritus is the primary symptom. So eczema is known as the itch that rashes. So they start with this itch, and they scratch and scratch and scratch, and they develop this severe itch, and it can look red and inflamed and yucky. Treatment, first you want to control the pruritus and hydrate the skin. This is a dry illness, a dry rash. So you want to educate the parents a lot about how to rehydrate the skin. And we'll talk about that in a second. But you also want to reduce the inflammation, preventing secondary infections. So the itching and they're scratching and it's open wound, and they can commonly develop a cellulitis with it. So there's 2 philosophies on how to rehydrate the skin. The first is the wet method. And that is frequent warm baths followed by a lubricant. So eat up to 4 times a day, getting them in the warm bath, getting them out. Don't even dry the skin all the way, putting on that lubricant while the skin is still moist. So you kind of trap in that moisture and re-moisturize the skin. And then there's the dry method. And this is infrequent bath. The thought that the bath is really drying out the skin. So you only want to bathe once or twice a week, but you want to use a non-lipid hydrophilic agent followed by the moisturizing. So that good soap to clean, that's the gentle soap that you can get over the counter, the eczema soaps. So Cetaphil, Aveeno, a lot of those make good soaps for eczema. And then moisturize, moisturize, moisturize. Apply a frequent hydration. The thicker and the greasier, the better. You're going to put that on probably at least 3 times a day and really rehydrate that area. And then you want to avoid irritants. And this you'll know based on where the eczema is, what that irritant may be. So it may be from a diaper. They may have tried a new brand or a new brand of wipe or something like that. So change that brand or wipe. It may be from their detergent, a new skin, a new soap. It may be from a food allergy. So that's a typical, if you see a very severe eczema in a infant, think about food allergies. They may be sensitive to milk. So really just cutting things out from their diet can help relieve that eczema. And if you get that severe eczema that you think might be from that, refer them to the allergist and get that tested. Then you want to control the itching. So using oatmeal, cornstarch, or baking soda baths, an oral histamine to stop the itching, and then medications you can do a topical corticosteroid, antihistamines, and then systemic antibiotics if you see a secondary cellulitis. Diaper dermatitis is another form of dermatitis. This is the most frequent contact dermatitis seen in children, and you'll see this a lot in your practice. For history, you want to know the type of diaper, any recent change in the brand, or any recent change in laundering products or wipes. You want to know the frequency of stools and wet diapers, and this is because a lot of times you can see this secondary to a diarrhea illness. It's so irritating, and a lot of times diarrhea is very acidotic, so it can be very irritating to the skin. And then any types of medications taken, such as antibiotics that can cause the diarrhea, which then can cause the dermatitis. For your physical exam, they'll have a shiny, peeling, erythematous, macular, or papular rash in the diaper area. The head of the penis may be erythematous or dry, and they may have an erythematous, macerated, or dried hypopigmented areas. Management, you want to keep that area dry, clean, and aerated. Change the diaper every 1 to 2 hours with a diaper change added in at night so they're not sitting in the wet diaper for too long. So I instruct my parents, get that diaper off as much as possible. Change them, clean them, let it get really dry, even let them run around naked for a little while and get a lot of air to the area. When I worked in the PICU, we would see this severe because these children would be on high-dose antibiotics, and so they would get the diarrhea and just have very severe excoriated diaper rash. We would actually take oxygen and put it in their diaper and kind of leave that area open with blowing oxygen on it, and that would help relieve that rash. Avoid using wipes. So I instruct the parents to just use a wet washcloth, or I know sometimes that can be hard, so in the PICU, we would take an old wipe container and clean it out to get any detergent out of there. We would put just gauze in there and get it just wet with, we would use sterile water in the PICU, or just water. And so they have them right there at their changing table. They stay wet, and they can use those to wipe that area so you're not using the detergent, because that can just burn and hurt so bad. Avoid the use of rubber or plastic pants. You want that air getting in there. Cloth diapers should be soaked, pre-rinsed, washed in mild soap, double rinsed with a 1/4 cup of vinegar, and then dried in the sun if possible. Sitz baths can be helpful in warm water for 10 to 15 minutes, using hydrocortisone 0.5 to 1% 3 times a day for no more than 5 days. Increase the fluid intake to dilute the urine. If it's not improved in 3 days, add a topical antifungal, so the clotrimazole. If still no improvement, add an oral antifungal, and then follow up frequently every 1 to 2 days by phone if this is really severe. And I don't think I mentioned the barrier ointment there at the top with zinc oxide. So using a really good barrier ointment, and there's so many of these out there. There's butt paste. A lot of pediatricians will have their own mixture that they like to use with a vitamin E or Desitin. We used to make one in the PICU that had antibacterial ointment, a Desitin, and the clotrimazole kind of mixed together. The next thing we're going to talk about is cradle cap. This is a chronic inflammatory dermatitis. It's cradle cap in infants and dandruff in adolescents. This is related to overproduction of sebum from the sebaceous glands. For your physical exam, it's not itchy and there's no pustules. In infants, you can see an erythematous, flaky to thick crust of yellow, greasy scales. It can be present on the face, scalp, behind the ears, on the neck, trunk, and even in the diaper area. In adolescents, you'll see mild flakes with some erythema and yellow, greasy scales present on the scalp, forehead, nasal bridge, and eyebrows. And of course, you'll see the typical white flakes that you see with dandruff. There's 3 types of agents that may be helpful. Your antifungals, so your azoles, and then the selenium sulfide shampoo. Just let the patient know you can buy the anti-dandruff shampoo at the dollar store, but some of them may not have the selenium in it. So teach them to look at the list of ingredients and make sure that's an anti-dandruff shampoo with the selenium in it. Anti-inflammatories can be used, topical steroids, topical calcineurin inhibitors can be used on the scalp, and then the keratolytic agents can be remove excess scales, and those are your topical salicylic acid. Other things you can do to management for infants, there's really no medical treatment that's approved by the FDA for children less than 2 years of age. For them, we recommend more natural treatment. So using a mineral oil, I've heard some people do coconut oil or olive oil, any of those will work. You kind of apply it and rub it into the scalp and leave it there for about 5 to 10 minutes, and then shampoo with a very mild baby soap. Once that oil is in there, you want to clean it with a soft brush, so kind of scrub those crusty areas with a toothbrush, a soft toothbrush, or a baby brush. For adolescents, if it's on the face, you'll want to use a daily ketoconazole 2% or intermittent low-potency topical corticosteroid. And then for your scalp, you're going to use a medicated shampoo 2 to 3 times a week, alternated with prescription strength shampoo. Leave the shampoo on for about 5 minutes and then scrub the crust and rinse it off. Treatment should continue a few days after the symptoms resolve. I mentioned earlier the pityriasis. Pityriasis rosea is another one. This is a mild, self-limiting papillosquamous disease of unknown etiology, but it's thought to be maybe viral. Minimally contagious, occurring more in the fall, early winter, and spring. It's more common in adolescents. 5% of them have a prodrome of malaise, pharyngitis, lymphadenopathy, and headache. So for your physical exam, you'll get 70% of them present with a Harrell patch. And if you look in that top picture, that larger erythematous area there is your Harrell patch. So they'll have this first, and then it spreads out from that. So it's 2 to 5 centimeter, solitary, slightly erythematous lesion with a finely scaled, slightly elevated border with central clearing. It's typically seen on the trunk, upper arm, neck, or thigh. And then your secondary lesions are symmetric, small, macular, papular, thin, and round to oval. And a lot of times you'll see this in a Christmas tree pattern. So if you look at that right, if you think about the spine as the center of the Christmas tree, and then it kind of spreads out looking like a Christmas tree. Itching is present in about 25% of patients, and about 16% of them have an oral lesion. Management, they'll use calamine lotion, tepid baths with Aveeno, antihistamines, and emollients. Minimal sun exposure is important. You don't want to use topical steroids, and spontaneous resolution usually occurs in 6 to 12 weeks. Acanthosis nigricans I want to touch on briefly. This is symmetric brown thickening of the skin. The skin develops a velvety, leathery surface, most commonly seen in the neck, groin, beltline, and dorsal surfaces of the fingers. It's not a skin disease, but a sign of an underlying problem. So it can be hereditary. Endocrine disorders are one of the things that can cause it, and that can be insulin resistance, hypothyroidism, hyperandrogenergic states, or Cushing syndrome. And this can be one of your primary symptoms of diabetes. So you want to get some blood work and see what's going on. Obesity can be a cause, and this is more common in the darker pigmented skins. Drug administration can cause this, so oral contraceptives or a high level of nicotinic acid, or it could be present from a malignancy, so Wilms tumor or adenocarcinoma. That was a lot. I hope this was helpful. Email me if you have any questions.